Hey everybody, it is Thursday, July 21st, 2022, and we just learned this morning that President Biden tested positive for COVID, and I thought it was worthwhile to jump on and have a couple minutes with one of our favorite doctors, Dr. Rutland, who will join us in just a moment. I have gotten many questions from you about this news that just broke just a little while ago, and one of the great questions I got, really important one, is why do we care if President Biden tested positive for COVID? A lot of people are testing positive for COVID, and so just to underscore that point, the president's health is always a matter of national concern because this is about national American leadership. And it's not just about American leadership here at home and the stability of American leadership. It also is a global story as well. So right now we know that the president tested positive this morning. We know a couple days ago when he tested negative. We know that his symptoms are mild according to the White House. But we're at an interesting point in the pandemic. And just as we jumped on and talked a little bit about President Trump's diagnosis when he tested positive for COVID, I thought it was worthwhile to talk a little bit about President Biden. Again, completely different situation. Just as we've talked about this week, we're seeing rising rates of COVID infection in the United States, but the data has been called, quote unquote, murky by the New York Times. I think that word really works because we know we're at a different point in the pandemic. We know people, perhaps our friends and family, have already tested positive for COVID once. Maybe some of them are vaccinated. Maybe some of them are not. We know that, maybe last year we would drive by testing sites, for example, on the road, and we're not seeing those anymore. A lot of people are testing at home. So whether or not the data is really painting an accurate picture of what's happening with COVID in America is another question. I know that's been a big question in the pandemic in general, but it's a big question for now. So this is consistent with the news, though. We are seeing rising rates of infection despite maybe difference of testing now. And the president now is a high-profile American who has tested positive. So what happens when a 79-year-old tests positive for COVID during this particular time? And that's why I wanted to bring in Dr. Rutland, who is going to join us here to talk a little bit about this. First time, I think, actually in the same state. Dr. Rutland is usually in California. And I'm in Texas. Now we're both in Colorado, but we're not in the same place, which is great. We're in the same time zone, which is nice, right? Yeah. So Dr. Rutland, what do you think about this? So you two treat a lot of people with COVID. Mm-hmm. If you get a call, hey, my 79-year-old father tested positive for COVID, what's the first thing that goes through your mind, no matter who that person is?
Treat them. Treat them. That's the first thing that goes through my mind. This is it's so interesting. I'm actually was really entertained by reading all the comments on the during your live when you were talking about everything. I found that entertaining. But treat them. And what do I mean by treat them? So, throughout this pandemic, what we've done is we've established certain risk factors for severe COVID, right? We've said, okay, if you have this condition, this condition, this condition, if you're this age, you have risk factors for severe COVID, you get therapy. If you don't have these risk factors, good luck. You just go about your business and hopefully you do well. I treat people. I treat all people, period. And so when people test positive for SARS-CoV-2 and there are treatment regimens out there, I give them the treatment regimen. Now, it's saying that Dr. Biden received Paxlovid, which we all know is an antiviral pill. And how that antiviral pill works, basically it doesn't allow the cleavage of proteins in the virus that are going to lead to its replication. So since this big polyprotein can't be cleaved into little pieces, it can't replicate. And so the virus inhibits the enzyme that cleaves that polyprotein. It inhibits that enzyme, so the virus won't replicate. So it's a good medicine. It works. Listen, everybody's always going to bring up, well, it was studied in people who aren't vaccinated. Like, who cares? It's not like their physiology is any different. But whatever. So there's that. But we also have a monoclonal antibody that is superior to all the others, right? And monoclonal antibody meaning an antibody that can bind to the spike protein, not allowing the virus to bind to your endothelium or your epithelium, activating the inflammatory response. And that monoclonal antibody that has risen, right, above everybody else is bebtelovimab. It's an antibody that I give in my clinic on a daily basis to people that test positive, especially a 79-year-old that tests positive for SARS-CoV-2. When they test positive for SARS-CoV-2, if they call me, I'm going to prescribe both Paxlovid and give them monoclonal antibody. I don't care what anybody says. I'm going to give them both because I want my patients to be treated. We all know that people who get SARS-CoV-2 infection, and if they're especially untreated, they're more likely to have long COVID, right? Persistent inflammation of their epithelium or endothelium, which is likely what it is. that causes symptoms of wherever that's taking place, whether it's taking place in the brain, whether it's taking place in the lung, whether it's taking place in the skin or kidney.
So we had a conversation about monoclonal antibodies just about a week ago, because I was looking at this new subvariant that's getting a lot of talk about that on the news, and I was checking it out, and I asked you because you had recently just tested positive for COVID for the very first time, and we were
I
talking
did.
about your treatment regimen. So you became a patient for a first time when it came to COVID on this, and I said, "Hey, doc, wait a minute. Do these monoclonal antibodies still work? I thought that they didn't work for these Omicron. I thought it didn't work for these. Wasn't that the talk?" And you said no, that's actually not true, and it's something that we should be aware of. So just, is that something that anybody should be asking about if they test positive for COVID? Should we all be asking again about monoclonal antibodies? And do you still think that's the best treatment out there?
It's the best treatment out there. And honestly, if I had it my way, honestly, and this is, if I were the end all be all, and I was included in these rooms, I would say everybody should be getting monoclonals. Everybody should be getting monoclonals. Like, we should just give them out. I gave myself a monoclonal and I took Paxlovid. Like, I'm not afraid to say that. Like, I gave myself both, right? And so I think that is what should have been spread from the very beginning. And I said this from the very beginning. My
You did.
point has not changed. I have
You
said,
have been consistent.
I have been very consistent. You treat people. I don't care if people are vaccinated or not. I think people should be vaccinated. I really do, but they're not. And I don't care. I'm still going to treat you, right? In fact, if you're not vaccinated, I'm going to give you even more of a priority. I want you to be treated as soon as possible. So yes, the monoclonal antibodies work, but there's only, I'm going to say 1.5 that work, right? One, bebtelovimab, we know that it works against BA4, BA5, BA2, all of it. Evusheld, which is texagevimab and silgagevimab, it's 2 monoclonal antibodies. It's AstraZeneca's product. It does have some activity against BA4 and BA5, not as much as
And
you would
those are
like.
those are the subvariants. When you're saying BA4 or BA5, those are the subvariants
Those
of
are the
Omicron
subvariants.
that's
Yeah,
circling around.
79% of people who are testing positive now, when you look for the subvariant, it's BA5. So that's what you're seeing 79% of the time. It's probably what I had. And so Evusheld doesn't work as well as bebtelovimab. So, and I'll be honest with you guys again, I'm going to Europe next week. I'm going to get a shot of bebtelovimab before I leave, right? I'm going to go to my office and get a shot.
As a preventative measure, as like just
I am. Yeah, I mean, it's an antibody. It floats around in your bloodstream. If you are exposed, or if SARS-CoV-2 is around, it's going to bind to it, right? It's going to not allow it to infect me per se, right? Or I won't have as strong symptoms likely. Now, is there any evidence for what I'm doing? No. But physiologically, does it make sense? Yes, right? Of course it makes sense. So
what are you thinking? So let me just go back to Paxlovid again for a second. As you mentioned, it's the antiviral. We've talked a lot about it. And it's also important to mention that in the past, at different points in the pandemic, monoclonal antibodies weren't available to everybody. The vaccine wasn't available to everybody. Paxlovid wasn't available to everybody. There were different, kind of these different groups that could get it or not.
Tiers,
so the only thing we know, tiers, thank you. The only thing we know about the president is the Paxlovid so far. So we'll watch for other treatments, and we're getting a lot of questions about the monoclonal antibodies. So I'm going to go back to that. But one of the issues that's come up about Paxlovid is this question about efficacy and how well it really works and rebound. Can you talk a little bit about rebound and what you've seen or what you think about that?
So I've been arguing with my friends a lot about rebound, and my friends say, well, Paxlovid doesn't work because there's rebound. And I said, just by saying the word rebound, you're telling me that it works, because you're telling me that their symptoms go away, but then you stop the therapy and then they come back. So are you telling me it's rebound, or are you telling me the therapy isn't long enough? So perhaps maybe the therapy isn't long enough, right? So perhaps maybe with Paxlovid, you need a longer course of therapy, more than the 5 days. Maybe you need 7 days, maybe you need 10 days. Have I seen it? Yeah, of course I've seen it. But I can tell you this, when I started seeing it, that's when I said, that's it, I'm done. Everybody's getting both. They're getting Paxlovid, they're getting a monoclonal antibody, and I haven't seen it since. So everybody that calls me.
So you're saying you haven't seen it since, if you give someone the monoclonal antibody with the Paxlovid?
Mm-hmm.
I see.
I haven't seen it.
So what else? Over the last 24 hours, the president made a comment where he, in speaking at an event that was unrelated to his health, made some sort of comment about having cancer. And he used the present tense. And so that caused some confusion. The White House has come out, I shouldn't say come out directly with a statement. From what I know, it was a White House deputy press secretary that tried to clarify the comments, because President Biden in the past has had skin cancer, not melanoma, but had skin cancer removed. And so, but again, this kind of rolled around the internet for the last, several hours. And so now you have this diagnosis. If you have any sort of past with cancer, whether it's skin cancer or anything else, how do you take that into how you treat people, and what should we be considering?
Okay, so here's the thing is you have this general term called cancer that means a bunch of different things, right? So cancer is essentially abnormal cell growth. And you have many different types of cells in your body, right? You have white blood cells, you have red blood cells, you have skin cells, you have eye cells, liver cells, all these types of cells, right? So it kind of depends on where the cancer is and what your cancer therapy was. In most situations, people with cancer, besides maybe a skin cancer, they're going to be given some sort of therapy that either inhibits cell growth, especially cells that grow fast, or they're going to be given a therapy that affects their immune system in some type of way, either activating their immune system, right, or inhibiting their immune system because that's where their cancer is, all right? So let's go a step further now. If you are given a therapy that inhibits cells that grow fast, because that's what cancer cells do, right? That's traditional chemotherapy. We all understand as physicians that white blood cells in your body are the cells that grow the fastest, and they grow every 6 hours. So we know that that white blood cell count, the cells that fight infection, recognize infection, make antibodies, all of that, they're not able to do their job. So they become severely immunocompromised, right? So that's why we worry about people who are being treated for cancer. If the cancer is in the white blood cell, say they have a lymphoma or leukemia or something of that sort, you are inhibiting those white blood cells from doing their job, right? So at the same rate, you're not going to be making the antibodies. So those individuals should most definitely be receiving monoclonal antibodies if they are infected. More importantly, if they have a lymphoma and they're on medication such as a rituximab, which inhibits B cells, these are cells that make antibodies, they should be given general antibodies every month, right? I prescribe this all the time. It's called IVIG or subcutaneous IgG. It's the most abundant antibody in your bloodstream, floats around your bloodstream, recognizing bad things, right? Somebody had mentioned the comment, your immune system is one of the most powerful things in your body. They're exactly right. It is one of the most powerful things in your body. And if your immune system is compromised in some way, shape, or form, you have to support it. Now, again, I'm biased because I always look at the immune system. I'm always paying attention to it, but most physicians are not that way. But these are things that you have to think about when you just say the word cancer. Like, we have cancer. I never allow my students who rotate with me to just say cancer. I'm like, nah, bro, like, you better tell me what type of cancer this is and how it's affecting their body. For people that ask, I'm a pulmonary, critical care, and internal medicine physician. I have 3 boards.
Thank you. I was going to follow up because we just had a question about, like, wait a minute, who exactly is Dr. Rutland again? What is he talking about with all this stuff? So this is really helpful. Let's just take Paxlovid aside. Let's take the vaccine aside. Let's take the monoclonal antibodies aside. If someone tests positive for COVID, whether they're 79 like the president or otherwise, do you suggest other things like vitamin D, sleep, melatonin? I don't know. We've heard a lot of things over the last couple of years, Dr. Rutland. What else should we be thinking about?
So everybody always asks about ivermectin. They ask about hydroxychloroquine, all these things that were out in the, in the beginning. I think what people have to recognize is in the very beginning, when you have nothing to give people, you always want to support them in every way that you can. Ivermectin, hydroxychloroquine, we use these things in some autoimmune conditions and calm down the inflammatory response. Not ivermectin so much, but hydroxychloroquine or Plaquenil we do. We give it to a lot of patients that have rheumatoid arthritis or something like that, just to calm down the inflammatory response. We know that it inhibits some cytokine behaviors, which leads to inflammation. Ivermectin, we know in a petri dish, it does similar things. It calms down inflammation, right? Telling the immune cells to kind of be quiet. That's why it got that interest. But in every single ivermectin study that there ever was, there is no real efficacy for it. So that's not to say that it doesn't work, right? It's not to say that I would say, like, hey, if you take ivermectin, you're the devil. I don't think that at all. I'm just saying that since there are therapies that are so much better out there, I'm not going to subject you by giving you an inferior therapy. I'm not going to make you a healthcare disparity, right? I'm not going to say, like if somebody came to my office and I had the monoclonals and I had Paxlovid and they said, hey, I want to take ivermectin, I would say, hey, listen, if you want to take ivermectin. But let me tell you, there are two other therapies that are so far superior. Why don't we focus on those, right? So that's what you have to do. And so a lot of people find it offensive and they get so upset that people want ivermectin or want Plaquenil and say, oh, it's the best and it always works and whatever. Like, you don't have to be offended by that. Just explain why, right? Just explain why you're using these other therapies. Test your patients for what's called common variable immune deficiency. Make sure that their IgG level is appropriate. If it's not appropriate, support them with IgG every month. I mean, I had a 36-year-old kid presented to the hospital with severe COVID. This was like in December or January of this year. He was going to die. He was on 100% oxygen, whatever. I treated him acutely. I did a lot. All right. I gave him a bunch of steroids. He got out of the hospital. Turns out when I checked his IgG level, this 36-year-old man, robust man, football coach, he had an IgG level that was like 300. It was really low. That was his risk for severe COVID. He didn't have any antibodies. His immune system didn't make antibodies to bind this virus, to get rid of it. So what do I do for him? I give him IVIG. Started him on it. He gets it every month, right? He gets it every single month to support his immune system, to make sure that he's as healthy as he can possibly be, and his immune system is as great as it possibly can be. Other things like vitamin D, there are receptors on white blood cells for vitamin D that allow the white blood cell to function efficiently. So your vitamin D level is appropriate. You want to make sure your vitamin D level is appropriate. So vitamin D, although not a therapy, it definitely supports your immune system. And so it's something that we all should be taking. We all need to be taking into account.
Interesting. So vitamin D. What about just Tylenol? I mean, at the beginning, that's the one thing that people were saying they do for COVID. Oh yeah, like get some rest, take some Tylenol, drink your fluids.
Yeah.
Very basic. There wasn't a lot available, and quite frankly, there's not always a lot available for people. I mean, I didn't even know to ask my doctor about monoclonal antibodies. I thought I wasn't even in the, I wasn't high risk. I wasn't particularly sick. But this idea of this question about long COVID and preventing long COVID, even if you have a mild case, is one that I think a lot of people are talking about. So, what about just like the basic stuff, the over-the-counter stuff?
Yeah, so I have feelings on Tylenol. And
I didn't know. I thought it was like a really easy question there, Dr.
Right.
Rutland.
No. Here are my feelings on Tylenol. So your body heats up under the presence of organisms because the organisms do not like heat, right? When you increase the heat in your body, the organisms die off, right? Tylenol tells your body not to mount a fever. In fact, when you look at literature in elderly people who cannot mount a fever, they are worse overall in sepsis and other types of diseases that include organisms, right? So I'm not one of those guys that passes out Tylenol. I'm not like, oh, take Tylenol. I will tell people to take it if they're miserable, right? And they want to get some sleep. Like, I'm a NyQuil advocate. I love NyQuil. I think NyQuil is the best. Like, I use it when I'm sick.
I'm going to call them for a sponsorship right after this, Dr. Rutland.
Dude, you better call them. I love NyQuil. It's the nighttime sniffling, sneezing, stuffy head, achy, so you can rest medicine. I love that stuff. I'm telling you right now.
Says the pulmonologist, you guys. It's not just anybody. It's the pulmonologist, okay?
I'm telling you. I do want to make one comment. I saw somebody talk about the FLCCC protocol.
Okay, what is that?
I don't know, the future doctors, whatever, the people that like ivermectin.
Okay, yes,
right?
Thank you.
You know what's number one on that FLCCC protocol? Monoclonal antibodies. So, like, don't get it twisted. Like, those guys know that too, right? That's what's number one. So they want you to get those before, ivermectin. Ivermectin's on that list too. I've seen it. I know it. I have patients that will email it to me. What are we not using in this protocol? And I was like, well, we are using the protocol. I just gave you the generic names. Go back and read your email, right? Anyway, it's just, it's such a...
Okay, so let's go back to the president. I promised that this would be a short conversation. It never is, and I really apologize for lying every time because I have the best intentions that it's going to be a short conversation. But we get started, and there's so many interesting things to talk about. So I know you're short on time, though. So for the president, let's say this is day one. The White House, we know that they're testing regularly.
I believe they said that he tested on Tuesday, tested negative. He had this event yesterday, so now it's Thursday. So let's say it's day one of him testing positive. What are you watching for over the next several days? Someone of his profile.
All right. So you're looking for the progression of symptoms, right? So what you worry about is you worry about end organs becoming inflamed, right? So you're going to ask about headache. You're going to ask about shortness of breath, cough, those types of things, right? Because if the lung gets inflamed, if the brain gets inflamed, if the kidneys get inflamed, the liver get inflamed, those are the organs that are end organs, right? There's
And what
nothing.
symptoms would that be? Like how would you know that? I mean, someone just looks sicker?
So lungs, easy. Cough, shortness of breath, can't do anything. Brain, kind of easy. Maybe really bad headache, can't get over the headache. Liver is a little bit tougher, right? You might have abdominal pain. You probably don't. You're going to check liver enzymes. Kidneys, kind of the same thing. Maybe you notice some blood in your urine. Maybe you don't. But it's very difficult to test for those things, right? Or to look at somebody and say, your kidney is inflamed. Your liver is inflamed, right? The person who can do that is Jesus. I can't do that. So you have to test for those things. You have to get liver function tests. You have to get a creatinine to look for the kidney to make sure it's not inflamed. But all in all, most of the time, it's going to affect the upper airway and the lower airway. So those things you can tell if you're getting worse or not. When I had COVID, I had the worst headache. My head weighed like 1,000 pounds for like 2 days. It was the worst. Right. And then I had started Paxlovid on day 3 of Paxlovid. I started to feel a little bit better. And then I gave myself the monoclonal antibody on day 4. But that was me. But those are how we evaluate these patients.
Okay, wait, let me ask you about this. Remember, I want to call everybody back. I know it's hard, like all the months kind of run together. But when when President Trump tested positive for COVID, he stayed at the White House for a short period of time, and then they moved him to Walter Reed. There's a private suite at Walter Reed for the president, where he was getting, what did he get? He got monoclonal antibodies at the time. Yeah. So do you think, I mean, this is not your regular patient. This is a president. I keep going back to his age, 79 years old.
No
do
doubt.
you think that would be wise? Would you leave if you were treating the president, obviously monoclonal antibodies would be something that'd be like, we're going to get on that.
He got him. There's no doubt in my mind that he got him.
Oh, you think so? Okay.
Oh,
well,
no,
I
no
don't know. The White House didn't list it. And usually they do.
They didn't list it. He got him. There's no doubt. Okay. He got him now. I don't care what they say. He got him. Like,
okay. Well, I'm going to double check with them. Usually we will see, again, as the news sort of develops, we'll be watching. We should get more information from the White House as to exactly what's going on. We should get reports on that. But would you move him to Walter Reed? Would you say, hey, Pres, like, let's just go over there because we have all the things there? Or would it matter to you at this point?
I mean, okay. All right. So I'm going to be honest. So obviously I voted for Joe Biden. Okay, guys, whatever. I'm a Democrat. Okay. But like,
you are? I didn't even know this is that far. Go ahead.
I look at him and I see him interact with, in life. He's not a healthy man. So yes, I would move him to Walter Reed. Like he is someone that needs to be watched.
You're saying he's not a healthy man. You just, by watching him, you have concerns about his health. Is that what you're saying? Just as a doctor?
Yeah, I have concerns.
Yeah. Okay. So you'd say, hey, doc, I always say, hey, doc, hey, Mr. President, let's go to Walter Reed. Let's just make sure you're getting everything that you need.
100%. No question. But in the White House, they have like a little mini hospital too. So like
they do. Yeah.
Kind of depends. But me, yeah, I would. If my grandfather was still alive and he was 79 years old, it would be the same thing. Like, 79-year-old men have 79 years of organ deterioration, right? Their heart's going to be not as good. Their lungs are going to be not as good. Their kidneys are going to be not as good. So when people like him, like them, when they get sick, like, yeah, I'm worried about them. If I get a phone call from one of my patients and I'm on call that night over the weekend or whatever, and they tell me they test positive for SARS-CoV-2 and they don't feel well at all, I'm kind of like, all right, here's what we're going to do. You're either going to go to the ER, and I'm going to come see you there to see how you're doing, or you're going to call me first thing in the morning and you're going to tell me how you feel. So you have to look after these individuals. And when these individuals are the president of the United States, you have to do what is necessary and what is appropriate. It's not something where you're just kind of like, oh, okay, just, go to your bed and Jill will be there. Like, no, you're going to look after it.
Well, it's not a political issue, right? As you're
No.
pointing out, this is about, and that's what I was trying to talk about a little bit at the beginning. It is about American leadership. It does have consequences. And so this is why we pay close attention. And even though we're going to approach it, Smarter News, in a nonpartisan fashion, we know that the White House, no matter who's in it, does have political calculations. This was a big decision by the President Trump's team to take him to Walter Reed, because it was the image of that. It was the photographs, the video of that. What did the president look like as he was walking to the helicopter? We remember that time. So this is something that the White House is going to be discussing as well. How would they do it? What would it look like? What sort of message does it send? And so this is another part of the story that we'll watch along with his health. So I'm going to let you go, Dr. Rutland. Is one headline that you're watching for over the next couple of days? And by the way, we all know you're going on vacation, which we're not going to bother you during that time, unless it's an absolute emergency, and that I probably will, and I apologize in advance. Anything you're looking for over the next couple of days when it comes from news from the president that you think we should also watch for?
Does he need oxygen? Does he need supplemental oxygen? If he needs supplemental oxygen, that tells me that, this virus is really affecting him. I don't expect this to happen, because I don't see a whole lot of patients in the ICU needing supplemental oxygen, especially if they're vaccinated, needing, with BA5 or something like that. I just don't see it.
And when you see supplemental oxygen, is that as simple as just like the little tubes that go
nasal
through
cannula?
your nose?
Yeah.
Okay. Just to be clear, because sometimes I think we think about full intubation, right? And that's not what you're talking about.
People, again, I'm a little biased because I'm one of those physicians that likes to act early. But when people need supplemental oxygen, even if it's 2 liters after not needing it, that means something. It's not like, people will say, oh, they're saturating 90% on room air. And I'm like, that's a big deal. Why are they not 100%? So that's something that you have to pay attention to. So yes, if he needs supplemental oxygen, that's not good.
Okay, we'll watch for that. And I just want everybody to know, I'll get Dr. Rutland. There's been a lot of questions about the monoclonal antibodies. I think this is a conversation we're going to have to return to when you get back from your trip, right before everybody starts school.
What's the question?
Well, no, I think we need to go deeper. The monoclonal antibodies has been a puzzle since the beginning. We've talked about it. Why isn't it getting more press? Why isn't it getting more access to more people? Does it matter? We've spent a lot of time talking about vaccinations. If we have a treatment that works, that has very little side effects, that can be used for all ages, even proactively. If we're going into a flu season again, where we're concerned about spreading virus in America, if we're also concerned about long COVID, why is this not getting the most attention? Why aren't all American families asking this question? Why is supply on the shelf going to be expiring? Who's going to be making more? What is the deal here? This is a real, we have had multiple, and let me just say this, we have had multiple people write into Smarter News and say your past conversations actually saved their lives because they didn't realize that they should ask about it. They asked about it and they got better. I'm not saying it's a panacea, but that's a really big deal. So, and as a journalist, I'm like, there's a lot of questions here that we need to talk about.
So this is why, is because people get better anyway, right? But the problem is that people might get better and then develop long COVID, right? And they might have something, but they're better, right? Or they're not in the hospital, or, they don't visit the doctor, but they get better, but they're still not quite right. For me, that doesn't mean that they're better just because they didn't go to the hospital, they didn't go to the ED, right? They have something, right? There's something going on in their body. So for me, there's just no question. I just give them monoclonals. Here's what I think is going to happen though. There's going to be a subcutaneous injection of monoclonal antibodies for SARS-CoV-2 infection. And I think
it's an IV, right? It's an IV right now. It's not a shot. You have to sit there. You have to get it. Okay.
Well, Evusheld, because I got it, is 2 shots, 1 in each butt.
Okay.
So I got that. That's subcutaneous, right? So I did get that. But it's not the acute monoclonal antibody, right? The Betelovimab, the one that works, is IV push. So now what they have to do is they have to study it subcutaneously to see if it still has its effect. And if it does, then it's going to be offered for people and you'll be able to purchase it. They'll come up with some qualifications and, insurance companies won't pay or they will pay, and that's always annoying. There are certain rules of monoclonal antibodies. They want it as an outpatient, but the way that I look at it is if the patient's in the ER, they're still technically an outpatient, so you can give it, right? I mean, just because you might be planning to admit them doesn't mean that they're an inpatient yet. you haven't converted them to inpatient. So take advantage of that window, physicians that are listening. So anyway, there are, the monoclonal thing is fascinating to me. And I got friends that are like, oh, why'd you give monoclonals? Like, they didn't need it. I'm like, what do you mean they didn't need it? How do you know they didn't need it? Like, they didn't qualify. I don't care if they qualified. I want to treat them. Is their body any different than that 65-year-old? Not really. Like, the 65-year-old just has more organ deterioration. So anyway, I can go on and on and on. But
This is what I'm talking
just
about.
as frustrated as you, right?
Yeah,
As
I just
everybody
think it's
on here.
interesting. And if you're telling me that it's, working, or if you're telling me it's wise because you don't know what exactly is going to work for each person, because we're still a little bit confused about why certain people are so affected by COVID and not others. Again, going into winter season where we know respiratory viruses, we always have them. So I think it's worth talking about. So maybe we'll have to set like a little monoclonal antibody happy hour conversation and take everyone's questions, on that.
Sure.
But I appreciate your insight about the president. What are you doing in Colorado, Dr. Rutland? What do you got going on today?
Giving lectures. I have to give a lecture on the immunology of asthma at noon, and then I have to give one at 6 p.m. tonight, and then tomorrow morning, and then I have to teach a course on it on Saturday.
So we're very grateful for your time. You always make time
No
for us.
problem.
I really
Yeah.
appreciate it. I text Dr. Rutland with all sorts of questions at all hours of the day related to COVID over the last 2 years, and I'm always very grateful, Dr.
And
Rutland. So thank you.
I want to say one thing, because people have been saying something. So the reason I don't talk all COVID all the time, guys, is because I know that it can be annoying. And so I stopped. So I only do it for Jenna when she asks me to. So if you look at my feed or my YouTube and stuff, you'll see a lot of COVID previously. You're not going to see it every day, because I think that it's like, I've said what I said. I haven't changed. It's there. So I'm sorry. If you have specific questions, DM me and I will respond. But as far as the everyday COVID business and me doing a post on the president getting COVID like every other social media person will do today, yeah, I'm not going to.
Wait a minute. Hey. It's
news.
This is I feel like we did it.
This is what you do, right?
We did it a little different today. I feel like we did it a little different, and I think we got a lot of really good information out. So I'm super grateful for that, because I think every time we have these conversations, you're very honest and you talk about actually helping people. At the end of the day, we want everyone to be healthy and safe. We don't say that out loud enough. No one says that out loud enough. I don't care your political party or your position. I want you to be happy, healthy, safe, and living your best life. That's what I want for you. So if that's the case, like, how do we talk about COVID in that context? And so I really appreciate that, Dr. Rutland. Thank you.
Than's for having me. How's my man True?
True Babbitt, it was screaming in the other room because I'm keeping him outside during this live. As we know, my 2-year-old has joined Dr. Rutland repeatedly during live, sometimes partly clothed, which then made me have to go back and edit it afterwards. So True Babin and Dr. Rutland have a special connection, and so I can't wait to see that meeting in person someday.
oh, it's gonna be great! I can't wait.
It's gonna be great. It's gonna be great.
Music.
All right, Dr.
All right,
Rutland, thank you very much. I'll talk to you later.
All right, bye-bye.
Well, we thank Dr. Rutland for his time. I know a lot of you are saying, hey, I want Dr. Rutland to be my doctor, which we do. We all want Dr. Rutland to be our doctor, which is why we want to make sure that you have access to him through Smarter News. And obviously, all of his Instagram accounts, you look up Dr. Jamie Rutland. He also has a YouTube channel that's really awesome, talks a lot about infection and viruses, and just a lot of really great news that's breaks down science in a way that is really accessible and great. So I'm really grateful that we found him. And by the way, found him through Instagram. So not all social media is bad all the time, right? If you have any other additional questions about what we talked about, please go ahead and put them in comments. We will continue to watch the status of the president in the United States. I think that's important. And no matter who's in the White House. And so we'll continue to see what news we learn, and maybe we learn a little bit more about treatments and you have some more context for it. Again, the first thing that we learned this morning and all we have is mild symptoms and Paxlovid. So we'll keep you posted. In the meantime, we got a lot of other news on our website, including, I don't know if you guys saw this story about how stress can affect your immune system, a new study on immune system aging because of stress. I don't know about you, but that's something I can really relate to over the last 2 years, right? So, or maybe just in general. Is that motherhood? Maybe just not the pandemic. It's all part of the same story. Thank you for sharing our story here at Smarter News as we try to build a solution in news, quick, concise, nonpartisan information that you can get throughout your day very seamlessly, where you're really the priority, because we do want to take care of you. And I want you to have a place to go where you can access information, get what you need, and then get on with your life, because that's what real good healthy news does, is it makes sure that you have the time to live your story, which is what we want for you. All right, guys, look forward to your questions and comments, and we'll have more on smarternews.com. I'm also going to take this video and post it on our YouTube channel, which sometimes is a little bit easier to watch than on an Instagram Live. So always remember, we have that as well as our podcast. And I'll see you with more on smarternews.com. Bye, guys.